Bienvenue à la réunion numéro.
We'll now open the meeting. Welcome to meeting number 28 of the House of Commons Standing Committee on Health.
Nous reconnaissons que nous nous réunissons sur le territoire.
Placed, as you can see, in a hybrid format, pursuant to standing orders. I just want to do some housekeeping and remind everyone of the following points. Please wait until I recognize you by name before speaking. And for those participating by video conference, please click on the microphone icon to activate your mic. And please mute yourself when you're not speaking. Otherwise, we will get ancillary noise. At the bottom of your screen, you can see an appropriate channel for interpretation. It's a little round global icon. You can pick whatever you want, whatever language you want. And a reminder that all comments should be addressed through the chair. For members in the room, if you wish to speak, please raise your hand, and the clerk and I will manage the speaking order as best we can, and we appreciate your patience and understanding in this regard. Pursuant to Standing Order on Tuesday, January the 27th, the committee shall commence its study on the Canadian Centre on Substance Use and Addiction. I would like to welcome our witnesses. They are Dr. Alexander Cordorella, Chief Executive Officer, Neil Araujo, Board Member, who is here by video conference, Scott Elliott, Board Member by video conference, Susan Russell Cesani, Board Member by video conference, Dr. Louis Hugo Francescucci, Board Member by video conference. And we have by video conference one of our committee members, MP Palm Baines. Now, this is how it's going to work. I'm going to give every person 5 minutes to speak. At a minute before your time is up, I'm literally going to give you a shout out and say 1 minute, and then 30 seconds so you can wrap up. If you cannot finish your presentation in that time, you have an opportunity during the question and answer session to elaborate on anything you felt you didn't get to say the first time around. So here, yes, sorry?
Just in recognition of that we did start 15 minutes late. So it is.
Always recognize that, Mr. Major.
Yeah, so we are going to have a full 2-hour
Yes,
meeting.
we will. We always
resources?
do. Yeah.
Okay.
We always do, just for future reference. We always do take into consideration when we begin and put 2 hours onto that. That's standard. Thank you.
Thank you for clarifying.
Okay, good. So we now begin with Ms. Dr. Cordorella. Begin for 5 minutes, please, Dr. Cordorella. Thank you.
Thank you, Madam Chair and honourable members. I'm Alex Cordorella, and I had the privilege of joining the CCSA 3 years ago as CEO. In 1988, all party support created the CCSA Act. It created this arm's-length charity to bring together expertise from across the country and to increase the participation of people in Canada. CCSA is the only national organization mandated to address both the health and public safety aspects of substance use. We work to address alcohol and other drug-related harms through a balanced approach that prioritizes both individual and collective well-being. As a family physician with experience across multiple provinces and territories, I bring evidence-based, compassionate, and collaborative leadership grounded in a need to have a real-world impact. CCSA's CEO is appointed by its board of directors and must be approved by the Governor and Council. This model reflects CCSA's status as an independent national organization created by and accountable to Parliament. CCSA's board is a volunteer board of directors made up of 13 members, and together they provide governance and strategic oversight I'm very thankful to have. The chair and up to 4 other directors are appointed by the Governor and Council, and 8 additional directors, members at large, are appointed by the board itself. Le CCDUS a de nombreux accomplissements à son actif, que ce soit les
CSA has many achievements, be it a report on addiction, which seems to be the most accurate description of use of drugs and alcohol.
Depuis lors, notre collaboration a donné la priorité aux nombreuses communautés que nous servons en travaillant avec elles pour mieux comprendre leurs besoins et en nous appuyant sur la science et les données factuelles pour les soutenir. Notre réseau de collaboration.
Say we're having some translation problems. When we're listening, those of us who are listening to the English can hear the French translation in the same booth. And so if we could fix that, shall we suspend until we fix it? Is it fixed? Is it fixable? Okay, thank you. Good. Well, let's go ahead then. Thanks. We've stopped the clock, so we didn't take your time. Go ahead, Dr.
Back to
Cauderella.
the part I did in French and do it again.
No, that's fine.
Oui?
Did everybody hear it? I think you didn't hear it? All right, could you start again then?
From the beginning or just from that?
No,
portion?
just from that point.
Okay, sure. Thank
So
you.
that's about four. You've taken about 30 seconds already. You didn't hear anything, Monsieur Blanchette? Okay, so we will start from the top. Sorry, Dr. Cauderella.
Oh, it's no problem.
Good.
Sorry you have to hear me say the same thing twice a little bit. I'll insert a new word. It's a surprise, perhaps. May I begin?
Go ahead, begin.
Thank you, Madam Chair and honorable members. I'm Alex Cauderella, and I had the privilege of joining CCSA as CEO 3 years ago. In 1988, with all party support, the CCSA Act created this arm's-length charity to bring together expertise from across the country and increase the participation of people in Canada on this matter. CCSA is the only national organization in Canada mandated to address both the health and public safety aspects of substance use. We work to address alcohol and other drug-related harms through a balanced approach that prioritizes both individual and collective well-being. As a family physician with experience across multiple provinces and territory, I bring evidence-based, compassionate, and collaborative leadership grounded in a need to have a real-world impact. CCSA's CEO is appointed by its board of directors and must be approved by the Governor and Council. The model reflects CCSA's status as an independent national organization created by and accountable to Parliament. CCSA's board is a volunteer board of directors. They're made up of 13 members that provide governance and strategic oversight. The chair and up to 4 other directors are appointed by the Governor and Council, and 8 additional directors, members at large, are selected and appointed by the board itself. Le CCDUS a de nombreux accomplissements à son actif. Que ce soit
CCS has many accomplishments, from launching the country's first addiction and recovery surveys to a Canadian Costs and Harms report repeatedly referred to globally as the most robust analysis of the provincial and national impacts of drugs and alcohol.
communities we serve, working with them to understand their needs and leveraging science, but also bringing that evidence directly to the grassroots. Our Sendu Data Network is a partnership of academics, governments, people with lived experience, law enforcement, and it was actually the first to raise the alarm about fentanyl in 2013. It has continued and expands now to exist in all provinces. I came to CCSA because of a pair of white shoes I couldn't forget. As a medical student, I met a 10-year-old girl who was crying that she was doomed to suffer a fate like her parents around alcohol. She was looking for a way to help her family. I remember her shoes, but not her face, because I couldn't bring myself to look at her because I had no tools. I felt so embarrassed. She wanted to build her community, and I came to CCSA because I see this as the vehicle to provide that support to communities so that they can find that help, that connection, and that future that little girl was looking for. We've been working to build hope and make it clear and easy for everyone to have a role in solving these issues, no matter who they are, setting them up for success. Our pediatric guidance work works with children's hospitals across the country to increase treatment access. Our small cities work is working with mayors of diverse backgrounds to find solutions that fit their communities. Our work with industries like trucking, mining, and tourism helps them solve these challenges unique to their fields. Canada's guidance on alcohol and health has put information into Canadians' hands to make their own health decisions. Our public education efforts have led to the most significant decrease in alcohol consumption ever recorded in Canada. Over the past 10 years, weekly consumption has gone from 10 to 9 drinks. That's 34 million less drinks of alcohol every week, a substantial and impactful decline. Les problèmes d'usage de substances touchent toutes les sphères de la
Substance use challenges every part of society, from health systems to families and communities, law enforcement, and governments. And an effective response requires collaboration across all sectors and at all levels. While communities across the country have common challenges, they're dealing with a series of distinct crises. We have to take into account the hyper-local contexts to find solutions.
Of people, organizations, and sectors across prevention, treatment, harm reduction, recovery,
One minute.
and public safety. I'm pleased, Madam Chair, with the committee's continued interest in substance use health, and my team and I remain available to provide the committee with the latest science, evidence, and best practices to help inform your work. Thank you for having me today.
Thank you very much, Dr. Cardorella. And I now go to Neil Arao, board member. Neil, for 5 minutes, please.
Madam Chair and members of the committee, thank you for the opportunity to be here today with you. My name is Neil Rao. I serve as a governor and council appointee to the board of the Canadian Centre on Substance Use and Addiction. I'm also a registered social worker here in British Columbia. And for my day job, I'm a CEO of one of the largest community-based health and social service organizations in Greater Vancouver. My career has spanned the mental health and substance use system. I began as a concurrent disorders clinician with Vancouver Coastal Health and worked at Vancouver Detox and the assertive community treatment teams, supporting people living with severe and persistent mental illness. I later managed mental health, substance use, and criminal justice programs, led psychosocial rehabilitation and pre-discharge units at the Forensic Psychiatric Hospital, and oversaw homelessness, housing, mental health, and substance use services as an executive director. Then in my spare time, I continue to practice privately as a counselor. Through this work, I have supported people experiencing substance use in emergency settings, treatment programs, justice systems, and within their homes. And from my perspective, substance use impacts people, families, communities, and systems in very interconnected ways. And in my work, I have seen approaches grounded in compassion and inclusion, where people with lived and living experience and families help shape responses. I've also seen the challenges that arise when accountability, evaluation, and evidence-informed approaches are not consistently applied. I joined the CCSA board because I believe this complex issue can benefit from perspectives across provinces, community-based organizations, clinical systems, and professions. CCSA's work, including its focus on accountability and quality in bed-based treatment settings, and its examination of the intersections between housing instability and substance use, reflects the importance of taking a systems-level approach. In my experience, when people speak about a continuum of care, there's often an absence, whether it's prevention, harm reduction, treatment, recovery, or enforcement. All these components must be discussed, not in isolation, and it must also reflect culturally relevant and community-based approaches within each stage. Approaches do not need to be mutually exclusive, and they can all be part of a coordinated system of care. Many of the people that I have worked with who experience significant substance use challenges have also experienced trauma over time. And addressing trauma early, supporting prevention, and providing people with tools and supports can influence longer-term outcomes. Recovery is supported when the systems that interact with people, including healthcare, housing, justice, education, and child welfare, are all aligned and responsive to their needs. As a board member, my role is governance, and this includes supporting scientific integrity, ensuring public funds are stewarded responsibly, and reinforcing the importance of accountability and outcome measurement. It also includes ensuring that CCSA continues to provide Parliament with balanced, evidence-informed guidance. Canadians expect compassion, they expect competence, and they expect accountability. Thank you, and I look forward to any questions.
Thank you. Thank you very much, Mr. Arao. I now go to Scott Elliott. Welcome, Scott. 5 minutes, please.
Madame la Présidente et honorable membres
Madam
du
Chair and honorable committee members, I'm Scott Elliott, and I'm from Vancouver, BC.
served as CEO of the Dr. Peter AIDS Foundation in Vancouver. Prior to this, I've been a senior executive and leader for notable organizations, as well as serving on numerous not-for-profit boards. I'm a gay, HIV, and Hep C positive man living through 39 years of active recovery for drug and alcohol addictions. Stigma, shame, and discrimination are not abstract concepts to me. I've lived with them for most of my life. However, rather than limit my ambitions, my lived realities have given direction to my career and purpose to my life. I have earned my voice as a trusted leader in the complex care space. It has shaped my empathy for Canadians who struggle with mental health issues and addiction. This is part and parcel of the reason I chose to volunteer as a board member for the Canadian Centre for Substance Use and Addiction. For my organization, the Dr. Peter Center, we've been operating since 1997. We manage a clinical day health program for more than 500 participants, a 24-hour licensed care residence, and enhanced supportive housing that balances dignity and healthcare. While we began as an AIDS organization, the center is never about serving just one population. So we have 28 years of experience working with what we call the Sideline 2%. The Sideline 2% is the nearly 750,000 Canadians who face extreme overlapping challenges: mental illness, addiction, homelessness, cognitive decline, trauma, institutionalized racism, medical issues, including HIV, HCV, etc. In my decades of experience, I've seen that there's many that will never be able to achieve sobriety, and there's many that will never live independently without support. I've seen over the decades, hundreds who have relapsed time and time again, and hundreds who've died because the support and services they needed did not exist for them. Today, I appear in this committee and provide witness testimony as a volunteer board member for the Canadian Centre for Substance Use and Addictions. The capacity of my role is to work alongside my fellow board members to further the CCSA's legislative mandate to provide leadership on substance use health and reduce alcohol, drug, and other addiction-related harms. The CCSA acts as an independent advisor to governments, producing evidence-based research to inform policy, programs, and public awareness, all the while fostering collaboration across sectors to improve community resiliency and safety. Working on the front line, I see innovative solutions every day. I also see that these solutions remain isolated in one program, in one city, in one province, when they could be informing practice across the country. Complex challenges like this require coordinated and strategic responses. They require strategic implementation across jurisdictions, and they require de-siloed funding and policies across health, housing, mental health, Indigenous services, and public safety. The CCSA has the mandate and the convening power to help bridge those gaps, connect evidence with action, and ensure Canadians across the country have access to effective care.
1 minute.
I believe this kind of leadership matters now more than ever. Thank you.
Thank you very much. I now go to Susan Russell. Is it Sani or Chani? What is it? Please tell me how to pronounce your name.
Chair, it is Chani. Thank you for asking.
Begin for 5 minutes, Ms. Chani.
Okay. Thank you, Chair and members of the committee, for the opportunity to speak with you today. My name is Susan Russell Chani. I bring to this work professional experience, governance experience, and first-hand experience supporting those in the intersectionalities of substance use, addiction, child welfare, and social systems. I spent the early part of my life in the foster care system, which has informed my understanding of how public systems interact over time and how gaps in coordination can affect outcomes for young people and families. That experience has shaped my professional interest in system effectiveness, risk reduction, and accountability. In my personal life, I have lost 5 people close to me to the harms related to substance use. 3, Adrian, Josh, and Catherine lived in British Columbia. Here, where I speak in Winnipeg, I lost my sister Andrea, as well as a young person that I worked closely with. 4 of the 5 individuals who died had prior involvement with the child welfare system. While each circumstance was different, This overlap reflects a broader, well-documented challenge in the intersection of child welfare, healthcare, and public safety systems. These experiences have reinforced the importance of timely intervention, continuity of care, and coordinated response that reduce health risks and community impacts. Professionally, I have worked across child welfare, health, and advocacy settings, and I am here today to speak to the intersections and the walks of life that the board, as a board member of the Canadian Centre on Substance Use and Addiction. My colleagues have already highlighted that CCSA is a national organization with a legislative mandate to provide objective, evidence-informed health and advice on substance use and addiction. Our work spans through public health and public safety. Our work supports government. Our work supports service providers and communities through research, surveillance, knowledge mobilization, and cross-sector collaboration. CCSA's mandate is to reduce substance-related harms while improving the safety, health, and population-level outcomes for all Canadians. As a member of the board of directors, my role is one of governance and stewardship. This includes upholding the CCSA's nonpartisan mandate while ensuring that the organization's work remains evidence-based, credible, and aligned with public interest and responsibilities. It is also to provide oversight, to support strong leadership, sound decision-making, and effective use of public resources. My perspective as a board member is formed by my frontline experience, my youth advocacy, and my work across multiple public systems. My work includes the appropriate and respectful inclusion as well of lived expertise, where it strengthens relevance to the programs and system effectiveness across all nonprofit, business, and political sectors. Beyond my role at CCSA, I am actively involved in community service. I am a founding and current member of the National Council of Youth Advocates, which works hand in hand to broaden the knowledge related to public health and public policy. My academic background includes a Bachelor of Kinesiology from the University of Manitoba with a focus on physical health, wellness, well-being, and along with a public policy certificate from the United Way. Together, those support my interest in prevention-oriented, health-centered approaches that contribute to public safety and system sustainability. I chose to join the CCSA board in January 2026 and serve alongside all of my colleagues who remain committed to fulfilling the governance responsibilities in support of evidence-informed, balanced approaches to substance use and addiction that protect both individual well-being and community safety. Thank you for your time, and I'll be pleased to take your questions.
Thank you very much, Ms. Chani. I now go to Dr. Luis Hugo Francescuti. Dr. Luis, for 5 minutes, please.
Merci, Madame la Présidente.
Thank you, Madam Chair, and thank you to the committee members. I left my beautiful province 46 years ago to go to Alberta, and I'm always happy when I have the opportunity to practice my French, but today I will be speaking English.
I'm 72 and I love what I do, and I'm still practicing at the Royal Alexandra Hospital in Edmonton, one of Canada's busiest emergency departments. As my colleagues have attested to, we do have a problem across the country with patients that present either homeless or with mental health issues or with addiction issues or all the above. These are without a doubt the most complex patients that we see in healthcare today. And so I'm excited. This is the highlight of my week to join you and to share a little bit about what I know, but more importantly, to find out what you know that we could do differently in our society to better meet the needs of these individuals. As past president of the Canadian Medical Association and past president of the Royal College of Physicians and Surgeons, and having sat on the board of Accreditation Canada and other organizations that are national, I think I bring a little bit of depth to the conversation. When I was asked to serve as chair of this board in December, it was an honor that I couldn't pass up. Having had one board meeting, the men and women that surround us and the staff at CCSA are amongst the best I've ever worked with. So if there's any way that the CCSA can be of value to you as you set policy in this area that is so important, and then try and bring along our partners in the provincial governments, territorial governments, and municipal governments as well, we're here to serve your needs. I look forward to any questions you may have today.
Thank you very much. And answer period. And I just wanted to let the witnesses know the question and answer period, if there's a time in it, whether it's 6 minutes or 5 minutes, that includes both the question and answer. So I'm going to ask you to be as concise as you can so we don't run over time and you don't get to finish what you're saying. So I begin for the Conservatives with Ms. Conants. Helena, begin.
Thank you to all of you for coming, and thank you for your work in the field of addiction. It's extremely important. This week marks the 10-year anniversary of BC's declaration of public health emergency due to the overdose crisis. And yet, since then, more Canadians have died of a deadly drug overdose than on every battlefield during the Second World War. 18,000 of them were British Columbians. There is a reason the Canadian press called this a decade of death. Overdose deaths peaked during the decriminalization pilot project in BC. Too many public spaces look unrecognizable compared to even a few years ago. Too many lives are still lost. Dr. Cottarella, during your testimony to the Senate in June 2024, you said that supervised consumption sites should become more embedded into the overall health and social systems as a front door to wellness. Is that still your advice to the Canadian government today for more drug consumption sites to be embedded across Canada?
So the context of that statement was to say that there's a need for an interconnectedness of care. And a supervised consumption site can't function on its own. It can't function independent from the community in which it sits either. So the idea, I think what I was trying to bring forward is you need systems that are connected with each other. If you're going to have open doors to wellness, you need ways for people to go from that supervised consumption site into treatment, into recovery, to see people like me in primary care. And I think a connected system is what we're talking about in this collaborative way.
I agree. We do need that system. I know in my community, if someone in a consumption site needs help, there is none for them. But I know you've spoken about these sites being accountable to the community, but many residents feel that they aren't accountable. These sites often create pockets of open drug use throughout communities and leave glass, needles, and tablets on playgrounds. In the spirit of a community accountability, would you support something like a buffer zone between these sites and local schools or daycares?
So I think with this, we need to understand that there are no one-size-fits-all solutions. Even in Ottawa, where I live now, when they're debating about where my son's school needs to go, the community is involved about where that school goes, what it looks like, what role it'll serve, and how we'll mitigate potential harms. I think blanket solutions don't meet local needs, which is part of the issue.
But do you think that a consumption site should be next to a playground?
I think there's a lot of context about where it is and what. I think that there's no reason that one can't balance safety and health. I think that...
So you think they should be? At times you're saying it could be next to a playground.
So I think that people have a right to feel safe. And if having a site near there doesn't make them feel safe, then the site shouldn't be there. Excellent. But if the community comes together and feels that they have a way to address it properly, then I think it should be the community's decision and everyone who lives in that community.
So you believe that a community should be able to vote democratically to see where a consumption site should be? Because I'm not sure that's happening, at least not in BC. I come from local government, and there were we didn't vote, or the community didn't vote on where the consumption sites would be.
So I think part of my issue has been that we read a lot about the tragic news in the newspaper, and then we say, oh, that's really sad. I really want everyone to feel that they have a role, not just around voting, but that they see themselves as active participants in helping their community members. I think when you look at where not only harm reduction, but treatment and recovery things have succeeded in the world, it is with that broad community uptake. So I think communities need to be involved, yes.
I agree. I think communities should have a vote in where consumption sites should go. Dr. Cottarella, this is really important. I view the decriminalization pilot project that happened in BC that was subjected to by Ottawa and Victoria as a costly and deadly failure. And I'm not the only one. Even Premier Eby said it did not work, and he said a year ago, or longer than a year ago, during the last election, he said it wasn't working. And Health Canada officials who appeared here refused to explain if they viewed it as a success. But others disagree. Like, for example, Dr. Bonnie Henry, BC's public health officer, said she was
55 seconds.
disappointed by the reversal of decriminalization in BC. What do you think? I mean, would you want to continue another decriminalization pilot program after the devastation it's caused in BC?
Well, quickly, what I'll say is I think when you talk to people, and I think when you look at the evidence, people want people to be healthy. I don't think they want end users to be criminalized. But you'll also, I've said that many times, but you'll also see in public statements I've made and the organization has made that law enforcement needs the tools to target organized crime.
Do you feel it worked in BC? Yes or no? Did this pilot project work in BC?
So CCSA wasn't involved in the rollout or the evaluation. I think that there are a lot of lessons to be learned.
Good. And was it successful? Would you do it again?
I think that it's a very complicated issue about what worked and what didn't work. I think ultimately we need
a lot of people died. A lot of people died. I would say that it didn't work. And I hope it's not being brought back
Ms. Kunans,
to any community again or any province.
May I ask, the time is up on this question, but I think, may I ask the committee to allow people to at least finish their sentences before we cut through them? I know this is a very tense subject, but can we let people just finish their sentences? And I think we can let the witnesses who bothered to come here to help us answer the question and finish a sentence. Thank you very much. I'm going to go now to Ms. Jasek for the Liberals. For 6 minutes, please.
Thank you, Chair. And thank you to all our witnesses for very interesting testimony. I will confess I had not heard of the Canadian Centre on Substance Use and Addiction until we came here to study it today. Even though I've been a practicing physician in Ontario for many years. However, when I look at the purpose in Section 3 of the Act, it certainly sounds an incredibly worthy purpose to promote increased awareness on the part of Canadians of matters relating to alcohol and drug abuse and their increased participation in the reduction of harm associated with such abuse, and to promote the use and effectiveness of programs of excellence that are relevant to alcohol and drug abuse. And certainly the board members that we heard from obviously have a great deal of experience themselves in relation to their own careers and so on. But my first question is for you, Dr. Cordarella. From a scientific point of view, I presume you collect data, first of all, as to the prevalence of substance abuse across Canada. Do you have full cooperation from provincial ministries, territories? How do you access the data to know the size of the problem?
Thank you. That's an excellent question. So there's a number of different things that we undertake. The first, as I mentioned before, we have a Canadian Substance Use Costs and Harm Study. Part of that is to look at over 20 different administrative databases, all the surveys that are done, all the vital statistics. And with that, we produce what we feel are the country's best prevalence estimates. It's where we see that alcohol has gone down, cannabis is increasing. We want to use it increasingly to help communities plan more for the future. In addition to that, we recognize that data is complicated. So this is where our network comes in, where we take all that data from drug seizures and surveys, and then we match that to what are everything from cops on the street to doctors in emergency rooms feeling and seeing, and how does that connect? It's why we've been able to produce recent reports on new additives in drugs or why deaths seem to be decreasing. And then in addition to that, we're working very closely with provinces and territories around some very specific data points. Right now, we're engaging in understanding what are both the number of treatment beds available in this country, but also what are the needs in each jurisdiction, and are we meeting them appropriately? We're looking at what services, basically all intended. We don't want to create data that's just on a shelf. We want to create data that people are action to use and that we're told people actually need. So we're very proud of the data work we do, and we're really looking forward to doing more and more in collaboration with literally hundreds of organizations in the country that we're very thankful to work with.
In other words, many of these organizations use your data and adapt what they are doing, presumably based on what the data tells them.
Yes, in addition to the data being very frequently referenced in provincial legislature, federal pieces, what we're hearing more and more is that, again, at that local level, people are using it to make decisions. It's why, for example, in our most recent project happening here in Ottawa, we're trying to take some of those costs and harms, some of those data points, and actually then apply them at this local level. Because ideally, as you're doing more and more, you should be seeing less criminal justice costs, seeing more appropriate housing costs, different pieces around this. And so we do see a lot of use of it, but we're pushing ourselves. And this has been a big goal of mine over the past 3 years that I've been here. You're a physician. You admit you hadn't heard too much of us. We are really working to change that. And this is part of why we're present at every big conference happening. We have relationships now and partnerships with most of the major organizations. We're working with cardiologists. We just published recently, for example, how they can do more to help patients who use drugs. So we're trying to reach people where they're at. We're working with primary care providers on alcohol to try and help them understand how they can do more to help people around cannabis as well. Physicians right now don't know what to say when people come through the door and say, should I smoke pot or not? And so this is where you're right, and we're actively working to have a bigger and bigger presence. And we're every day we have more partners. It makes me very proud that we're working more with people.
1 minute, 10 seconds.
And so maybe you could give us an example of the Act actually references programs of excellence. Could you point to a specific initiative that seems to have been resulting in positive effect?
Yeah, absolutely. This is where I'll talk about our small cities initiative a little bit. Again, we want things that land in people's backyards better. It's not just does it work in the evidence, is it implementable? So 2 projects that came up and we were able to feature, one was in Lethbridge. It was to say that, you know what, if that day you decided you didn't want to use drugs and you wanted help, you could find a low barrier job. Yes,
30. You've got 30.
You could find a low barrier job that day to help clean those streets and help build towards it, and you'd be paid for that. Similarly, in our small cities, we worked with Timmins, Ontario. Suboxone or opioid agonist treatment is still hard to come by, and we don't have high enough treatment rates across the country. What they did is they got their paramedics to be able to dispense on the site so that somebody didn't need to see a doctor right away. They could start feeling well that very minute. I just don't want to look away from some of the best innovations happening in some of the smallest places in this country. And I think one of the biggest lessons we've learned is we don't need to just look at Toronto, Vancouver, and Montreal to see what's happening. There's some best practices coming from across the country, and our job is to make sure that those are interconnected.
Thank you, Dr. Cook. We'll now go to Monsieur Blanchette-Jonca for 6 minutes, please.
Thank you, Madam Chair. I'd like to welcome the witnesses with us today. First question for Dr. Cauderella. Thank you for being here with us. Simple question. Have you observed that the fight against the opioid crisis is a priority for the federal government over the past 15 years? I would say that it has been a priority, but for various governments in various ways. The reality was that there was so much suffering that often we want to be the hero of the story. But what we're discovering is that there's not a single minister, a single government who will be recognized as a hero. It'll be millions of things. So I would say that this federal government has done a lot, but what we have to see more often is that various departments work together, and also that various levels of government work together. We want the federal government to work with the provincial and territorial governments and also with the municipal governments. But talking about governments working together, I'll give you a concrete example. For more than 15 years, Quebec is recognizing the expertise of pharmacists to intervene in certain cases for the opioid crisis. They have the skills, they have accessibilities, not just in urban centers, but also in remote regions. They have field experience, but the federal government prevents the Quebec government to act on a regulation to go further, so that when there's an opioid crisis, they're not allowed to have the status of practitioners who can intervene and fight against this. I'd like you to tell me more about that. How is there that no one in the government has considered that to be a solution? The Quebec government has been asking for that for 15 years. So I'm wondering, are they people who don't understand? They don't have the skills? Are those suffering from opioid consumption, and in the government they can't act? Well, I don't work for Health Canada. I don't work for the government. But what I can tell you is that a few weeks ago, we spent a day together in Montreal, and what we were talking about was why is it that the results in Quebec are much better than what we hear in France or in the rest of the country. I give presentations, and you know that there are many people in this country who didn't know that the death rates in Quebec were 20% that in Ontario, if we look at Rouyn-Noranda and Timmins. So that's our goal now, and really we're working, we've been very successful. How can we teach to the rest of the country what Quebec does, and vice versa? So I don't think we're doing miracles, but why are we slowing down clinical interventions that are useful and that could reduce risks for patients in terms of opioids? So it's been 15 years. I think it's unbelievable that the government is asking for something and they don't take action. But that's Quebec example. But other provinces asked for some official recognition of the status of a pharmacist. So a pharmacist cannot intervene quickly to decrease the risk and use. Does that not harm the safety of patients? Excellent question, and I'd like to say that. Whereas the centre wants to hear from the provinces as well. If there are problems there, the centre could write a report for saying what the recommendations would be from the provinces. So I can't tell you why the federal government does one thing or another, but we could help you. In Quebec, let's say, how could we help to have a better response in these issues? So I'm saying that there's always a time delay before professionals can treat people who are consuming. So in some cases, you can terminate a prescription. During the pandemic, we saw lots of changes in the way methadone was dispensed and who could get it and how. That was interesting. And
thing is, I think we sometimes focus a lot on what we're doing. We don't focus on how we're doing it and if we're doing enough of it. And so we're always looking for the perfect solution. I think that there's a mix of we probably do some things too fast and don't look at it closely. And there's other things we wait and don't do. And this isn't just with the federal government. C'est avec les gouvernements provinciaux, territoriaux,
it's also with
différentes choses.
the provincial and territorial governments. I think we could see much more action. I agree with you entirely. So you're really highlighting a serious problem in the healthcare system. We're in a mode of reaction rather than prevention. And science shows us with prevention, we save money and we decrease risks. So does our system use pharmacists enough as actors that can decrease addiction? I'll say that I'm not an expert in that particular subject, but with all members of the healthcare system. People are not used enough. As a doctor, I can tell you when one of my patients does not do well, it's almost always the pharmacist who calls me rather than the patient who comes to see it. Does that mean that every private drugstore should increase the amount of prescriptions? If there are too many prescriptions, too many problems, things have to be dealt with in the proper way. But we have to be creative. There's no question.
Merci beaucoup.
There's a 5-minute round with the exception of Mr. Blanchette-Jonca, who gets 6 minutes because he's a very special person. Thank you. So we begin with the 5-minute round with Mr. Major for 5 minutes for the Conservatives. Thank you.
Thank you, Chair. Dr. Cottarella, who provides the main source of funding to the Canadian Centre of Substance Use and Addiction?
So the majority of our funding, and all of this is publicly available on our website, but the majority of our funding comes from a contribution agreement from Health Canada and the Government of Canada. We also receive
that
funding.
Answered the question. Thank you. According to the most recent annual report, the centre received more than $11.5 million from Health Canada last year. Is that correct?
I believe last year we received, yes, it's probably correct, yes, $11.5 million.
Okay. That same annual report shows that nearly $9 million was spent on salaries and employee benefits, which accounts for nearly 70% of your revenues. Is that correct?
Yeah, we've actually been making a lot of efforts over the past 3 years to move things in-house as opposed to relying on contractors, and we've been able to recruit some of the world's best scientists to come work directly for us.
Because last year on contractors, you spent $1.8 million plus on contractors, so got a ways to go. As CEO of a federally funded organization, what is your total annual compensation, including salary and bonuses?
My annual compensation with bonuses, I believe, is $270,000.
In 2021, you wrote a letter to Health Canada in support of decriminalization the possession of hard drugs in Toronto. The letter stated, and I quote, "I write this letter of support for Toronto Public Health decision to submit a drugs possession decriminalization exemption to Health Canada." Can you confirm that you signed this letter? Yes or no?
Yes, that would have been before I came to the CCSA when I was a physician at a hospital in downtown Toronto. But yes, I signed it. I believe in that year there were only 3 arrests for possession from the Toronto Police Service. And I think there had been a desire to find greater ways to, again, pursue organized crime and violent crime.
You answered the question. Yep. So in the same letter, letter to Health Canada, you also wrote, and I quote, "Decriminalization should be seen as having minimal risk." Do you still believe that decriminalization has minimal risk? Yes or no?
So your colleague asked a question about decriminalization, and I think we made a mistake around people didn't have the right expectations.
Do you still believe that decriminalization has minimal risk? Just yes or no? Even what you learned, do you still think that?
I think in this country there's almost no arrests for possession right now. I don't think that the decriminalization of simple use is what caused an increase in violence or deaths. What did happen, though, is that there's a lot of considerations around things like public use, how law enforcement and health are going to work together.
Yeah, and we'll get to the public use here in a minute. Dr. Cottarella, do you support decriminalizing hard drugs all across Canada? Yes or no?
So if you look, we have produced an evidence brief around decriminalization.
Do you support decriminalization all across Canada? Yes or no?
So for the end person who uses drugs in small amounts, there is no benefit to long and often ineffective prison sentences. And so I think that it's important to look and consider. Now, that being said...
So you still support it? Yes?
What I think is that...
It was a simple yes or no.
Well, but...
You did try to qualify it, but it is... You still support that?
What you heard me before say, Mr. Mazur, is that I think that every community needs to find its own solutions. Okay. And this may not be the right fit right now for every community. I feel that the evidence supports its overall benefit and use, but there needs to be community buy-in and support.
Before any other testimony. Dr. Cottarelli, the Globe and Mail reported health authorities in BC tried to allow the purchase of regulated heroin without a prescription.
39 seconds.
The health authorities also tried to create, and I quote, heroin compassion clubs. Do you believe that regulated heroin has a role in treating addiction in Canada? Yes or no?
So there is evidence for heroin-assisted treatment.
Are you aware? Yes or no? Because I'm tight on time.
I think that regulation of drugs is a very complicated issue, and I think that there's a lot to be said about
I have one last question.
public
It's very
safety
quick.
preventions.
Are you aware that daycares have been forced to shut down after supervised consumption sites open near to them? Yes or no?
Yes.
Do you believe...
Time is up, Mr. Major. And I'm going to go to Ms. Sidhu for the Liberals for 5 minutes, please.
Thank you, Madam Chair. Thank you, all the witnesses, for being here with us. My question is to Dr. Cottarella. Dr. Cottarella, how have federal investment in substance use programs improved coordination and outcomes across Canada? You were talking about the wraparound services. You said in your remarks you were talking to the cardiology when the people are going to cardiologist or primary health care. Can you talk about that?
Absolutely. I mean, one of the things we sometimes talk about is how did we tackle smoking? We made it a whole health issue. It didn't matter where you went. Every door was a door to be supported, treated, helped. Now, I mean, obviously this is very different in this context, but I believe very strongly that, and I believe in the power of primary care to deliver many of the services, including opioid agonist treatment, and most of the things that are most needed. But people need support, and they need coaching, and they need help. And they need to be able to individualize these solutions to their local realities. It's why, for example, we're involved in national leading efforts to do work around measurement-based care. How do you measure and make sure people are improving? How do you provide good concurrent disorders? And I think that what we also are seeing increasingly, which is really nice, and maybe this is a reality of a little bit more fiscal austerity, is we're seeing organizations wanting to work together. We're seeing governments wanting to work together. We're seeing people wanting to find the solutions. Being right, but having, as Mr. Major was saying there, daycares closing and people that are upset and frustrated isn't a solution. So how do we all work together? What I'm finding is when I go out and I tell people that they can have a role, that they can do something about this, that as a primary care physician, we can help you. I met with tons of enthusiasm. One of my colleagues who's here, for example, went and met all of the newcomer clinics and centers. They're very keen to find ways to support their communities. So our job is to be able to reach more people in a more timely way.
Early intervention is important. How important is prevention? And Canada's taking this government is taking a balanced approach that includes prevention, treatment, and recovery. Why is it critical that Canada stays grounded in evidence, and how does your organization can support that?
Yeah, so I think that there's the piece about evidence. And then there's how people see themselves in that evidence and how that evidence is provided to them in a way that's useful. Again, people I don't think are done with data. People want data, but they want data that resonates with them and is useful. I think that's how we move things forward in an evidence-based way. If people see themselves as part of these processes and solutions, things get better. And I think that when it comes to the need for that evidence, we also, people, it has been 10 years of these issues. And at first, I think people very appropriately responded with the here and the now. But the youth, if you're 18 or 19 or 20 that you're dying of an overdose now, you were 8 at the beginning of this crisis. We need to look across this prevention recovery spectrum. So it is absolutely very important. And we need to recognize that every single person who goes through treatment is going to go back into a community that needs to support them. And so this is, I think, part of the nuance around questions we were being asked around regulated drugs or different pieces, because ultimately community needs to provide an environment that supports the healthiest well-being possible.
And what opportunities do you see
1 minute.
the further strengthen collaboration with the federal government to build on the progress we can make more?
So I think there's a few big elements. One is there isn't a prevention workforce in this country yet. And I think that there's probably a lot of roles that things can do. I think the second part is when we look at, I think most people in this country, unfortunately, aren't even able to access the care that is available to them. So when we look at how things like federal government roles can support making sure that all of the provincially available services are actually in grasp and in hands, can be really important. The last thing I'll say is I think that the federal government can have a really important role where its levers are there, but I think also it has a role as a partner to the provinces and territories and other levels of government. And I think we're seeing an emergence of that ability for these different levels of government to work together. In the past, CCSA has been a big support in terms of creating that.
Thank you. Thank you, Blanchette-Joncard, for 6 minutes, please.
Thank you, Madam Chair. Dr. Catarella, we were talking about the prescription authorization, but also de-prescription. Pharmacists now cannot end prescriptions to patients when they don't need them anymore. Does that not have an effect on addictions and connected risks? The issue of de-prescription, ending prescription, is very important. What we did for the last 2 years, we were trying to de-prescribe for many people without necessarily giving them a solution to help them in their treatment or having drugs that would compensate for that. This is a personal opinion here. But I would say the transition, well, it's the pharmacists who can realize that there's a problem, and I would like to see them be able to connect people directly to treatments if they're afraid that the person who's prescribing it is not being diligent enough. I'm taking the data from your organization says that the misunderstanding of the risk of prescriptions, frequent prescriptions of strong doses of opioids to relieve pain is one of the main factors contributing to the opioid crisis. So the first force are the pharmacists, and they don't have the status to be able to intervene. For 15 years, the Quebec government's been asking for it, and nothing's changing. What's happening? I would love to talk to you about my organization to find more data in this field. I say that it's clear that we're not using all the members of the healthcare system enough. So if you could give us that, if we could get that, it's certainly something that's needed. Your main funding from Health Canada ended on March 31st, 2026. Yes, we signed a new agreement a few weeks ago for the next 5 years with Health Canada. Centered on the idea that what we're doing is exactly what's been described here. No, the funding is still the same. It's 10 million years. Is there indexation? No. If it's not indexed, it's a decrease in funding. Well, we understand that the reality these days is one of financial restrictions. So that's why we're also receiving money from provinces and various organizations. And our organization is to grow. Our aim is to grow as an organization. But I think someone wants to create a strong Canada. That's the miracle slogan. And on 2024, the Canadian government recognized that the overdose crisis was the most serious public health crisis that Canada ever knew. So you're saying they're not increasing your funding, and you'll be able to fight in this most serious public health crisis that's ever existed in Canada. Is there a miracle that your organization is doing? Well, we would, of course, like there to be more funds, but it means I can't ensure that the money that's given to, if you give me 5 million or 15 million, I'll do my best. In this field, as you said, we're carrying out training, and we're very happy that Health Canada gave us money to do that. Training with mining, oil and gas, and all these various sectors. As you said, in order to build a strong Canada, we have to help them. So I'm trying to understand the contradiction between the government's message and government's actions. I know you're not responsible for that, but I'm just trying to analyze this as a lawmaker and influencer of public policy of health in Canada. So the government has said it's the worst crisis in history, but they're not even indexing the budget. I have difficulty believing that that won't have any impact on your operations and your activities. Well, as I said, we would always like to have more money. What's very useful, it's that our organization did several things to reduce our expenses for internal functions, financial systems. So we try to do the best we can and try and reduce our expenses. As we said earlier, we're trying to have more and more scientists within the organization, and that way we could be doing better. Well, I want to help you in your work. What is the concrete impact for your activities and programs that are affected by this decrease in funding? Frankly, we're trying to do more. I know that you want me. So I have difficulty understanding that. You have 10 seconds left.
Alors, s'il vous plaît, concluez.
Complète.
Okay, I'm unable to get a complete answer.
Mr. Strauss, for 5 minutes, please.
Thank you, Madam Chair. Dr. Cottarella, may I begin by saying how much I appreciate the expertise and enthusiasm you're bringing to your testimony. It seems like you're a very data-driven guy. I am too. I appreciate that. In preparation for for this study, I was trying to find substance disorder rates for Canada as a whole, and when I was doing a web search for that, your organization came up. So obviously you have a role to play in coming up with it. But I was concerned because on your website, I found a November 2022 paper on the rate of opioid use disorder, and to my read of it, it had data up to 2019. I also found a paper on the use of methamphetamine use, and that report was dated 2020, and it had data, as far as I could tell, up to 2017. Do you have more up-to-date data? Is it on your website? Am I just missing it, or?
Yeah, so we're in the process of rejuvenating parts of our website, and it's kind of a work in progress. Again, it's one of those things that we've brought in-house to try and save some funds, but the team there is doing a fantastic job with it. But to your question, yes, we do. So we have prevalence estimates up to the end of 2024. They are available directly on our website or through the CSUSCH.ca, which is a microsite we've set up. There is a prevalence tool that actually is interactive where people can look and not only look at the rates of stimulant use, opioid use, but also break it up by province, men, women, different things as well, so that you can get the data that's most
that link with
Absolutely.
the committee, because I failed to find it myself. So can you tell me, is the prevalence of substance use disorder in Canada going up or down broadly by your lights?
So one of the things we're, I think, more confident on is how much use there is. The problem with the substance use disorder is how it's diagnosed and by whom and how surveys are done has changed over time. So this is where we've tried to make different pictures and assessments and assumptions around it. And absolutely,
Can you give me your broad sense as a like? I understand you should slice and dice it. I'm not going to gotcha and say what about this paper. I'm just asking for your broad sense as a clinician and as a leader in the field. Is this trending up or is this trending down?
So I think it's an excellent question. I think that again, because of the assessment rates are changing so much, it is a hard question. I can come back with a more specific written answer. But for opioids, and we believe it to be relatively flat, if decreasing a bit. We're concerned that there's increasing use potentially amongst young people, but that there's less substance use disorder potentially in others. We're concerned about substance use disorder rates that are increasing, for example, for cannabis in older adults. And so this particular...
Thank you for that. And I hope to come to my own conclusion when I go through your data. I'm an ICU physician. I became very frustrated in some respects with my practice. It's very downstream, and there's some preventative medicine and family medicine specialists here who are more concerned about upstream things. But it seems to me that a lot of the talk, when we talk about how as a society we're going to deal with addictions, we talk about the crisis, we talk about deaths, we talk about consumption, but ought we not to be more obsessed with upstream interventions? Like, how do we prevent kids from getting on this in the first place? And I haven't heard anything about that so far today.
Yeah, so we actually not only created the first prevention standards for community, school-based, and family, but we have a whole sector of our organization dedicated to that. When we look at that next contribution agreement, not only are we focusing a lot on prevention, but we're also focusing specifically on youth. And so I think your question is a good one. When we're talking about working with cities, when we're talking about working with this upstream work, there is a tremendous amount. When we're talking about the Canada's guidance on alcohol and health, we're trying to make it a more upstream conversation.
Related, but it's going to sound very different.
Do
you think that drinking and driving should be stigmatized in our society?
So you're asking a good question about, is there such a thing as good stigma or bad stigma? When I was bringing up smoking, for example, was there good stigma that pushed people off of it? Probably yes. Did it go too far, where now people are so afraid to even identify and maybe seek treatment? Perhaps. This is where we need to look at honestly balance. We need a balance in society where people feel that people shouldn't be punished because the people use drugs, that they need help.
Times I'm going to interrupt you. Thank you so much for saying that, because we've had department officials come and say that the Department of Health is here to fight stigma around substance use disorder. And I guess the conservative position is really that when we do these harm reduction sorts of things, are we like, I'm a clinician, I'm focused on patients, I'm focused on my patients, but there's a greater societal, cultural cost potentially when we drop a consumption site next to a high school. And would you agree that potential for social harm with respect to upstream interventions and preventing people from getting on the stuff in the first place?
Thank you. We've gone over time. Maybe you can address that in another question. Dr. Cordarella, I'm going to go to Ms. Chi for 5 minutes.
Thank you, Chair, and thank you to all our witnesses for coming today. I read through some of the bios of the witnesses, very impressive background. So my first couple of questions is going to be for Dr. Francescuti. Did I pronounce your name right?
Yes.
Okay, excellent. So you're an emergency room doctor, right? Emergency department doctor?
That's correct.
Yeah, and from your perspective, what are the substance use related pressures you have been seeing very often in the front line?
Well, as you know, they're great. So we have a variety of patients that present in our emergency department. Some of them have substance use issues. A lot of them have mental health issues. A lot of them have chronic issues. And so some of your committee members were asking for solutions upstream. We've found a solution. We've created a program called Bridge Healing that immediately takes someone that's homeless, that's willing to go to a purpose-built building, 3 stories, in a community run by an NGO, and we provide them the opportunity to get their life back on track. It's free of charge. They can stay as long as they need to. We have 3 buildings that are harm reduction, 1 building that's sober living, so that we meet the needs of our clients. But we're able to take them from chaos, which is being homeless in an emergency department, and putting them into their own room. And they tell us probably the most therapeutic thing we give them is a lock on their door. And then they sleep for a day or two, they wake up, And then we help them. We get them ID. We open a bank account. We find out if they have legal issues. And then we find out what they want to do with their life. And we help them with social workers, with pharmacists, with addiction counselors. And we start the journey of recovery. And for those that go through the program, there's about an 80% reduction in return visits to the emergency room. And so we're scaling up right now in Edmonton. The municipal government is giving us free land. We have our Royal Alexander Hospital Foundation gave us a $10 million donation to get started. And then working with the feds and the province that's providing the operating dollars, we're actually helping these people that have very complex lives. My only advice to this committee is this is not a simple issue you're dealing with, and you know that. It's very complex, and we still don't know how complex it is. That's why CCSA bringing evidence that can allow policymakers to make really good decisions is crucial.
Yeah, thank you for that. And this bridge healing program sounds really interesting in terms of addressing some of, I see as probably gaps in the current system. And when you say scaling up, now you're doing it in Edmonton, what are some of your maybe future plans on scaling it in other provinces and hopefully a connected network across the country?
Right. Well, we're working out the models so that others can come to us and say, how did you do it? In Edmonton right now, we want to create a healing house in every distinct neighborhood. There's over 300. And if we were to do that successfully, and we will, it would mean that we would be able to eliminate homelessness in Edmonton within, 4 or 5 years. And what that does is it frees up capacity so that we can make absolutely sure that we stay ahead of the game. And as others have said, we try and prevent people ending up in this situation. I've yet to meet an addict that wants to be an addict. I've yet to meet someone that's homeless that wants to be homeless. These men and women are reaching out for us, and they're asking for our help. And I can't tell you enough about the moral distress that it causes us as healthcare providers to treat them and street them. There should be a law in Canada that says if someone shows up at a healthcare facility that's homeless, they should not be discharged into homelessness. That would be a bold vision for creating a stronger Canada.
Thank you so much for all the work that you do. And my next question is for Mr. Scott Elliott. Okay, yeah, there we go. In your opening remarks, you mentioned, innovative solutions that you've seen in your work and the potential for scaling. I just wanted to see if you can share a couple of examples and also share some of the challenges you've been seeing in terms of scaling. What are some of the things that either community or government can do to support that?
You have 25
Absolutely.
seconds in which to do that.
Thank you for the question. I'll just give a brief example of the Dr. Peter Center and how we function. It's a holistic care model. So when someone comes into the center, normally people would access our facility and they would probably come because we serve great food. They would come for breakfast or lunch. And then they get in there, they get put into a path of care. So we have got nurses and nurse practitioners on board that are able to look at them, work with them immediately. We then, over time, will get the people into therapeutic sessions such as art therapy, music therapy, counseling. And then, as I mentioned, we've also got housing programs and then subacute nursing care.
Thank you very much. The time is follow up on that in another round. Thank you. So thanks very much, Ms. Chi. And I'm going to go now to the third round. Is it Mr. Baber or Barber?
Baber is good.
Baber.
Thank you,
Mr. Baber, for 5 minutes, please.
Thank you very much, Chair. And thank you very much and welcome, Dr. Cadarella. I understand that you're a strong proponent of safe supply.
I'm not sure where you would have obtained that information.
Okay, well, you're an advocate of safe injection sites.
I think one of the things that's been unfortunate is, harm reduction's been around for 30 years, and I think we need to be very careful not to look at the different pieces in different ways. I think that when we talk about supervised consumption site, when we talk about injectable opioid agonist treatment, when we talk about safe supply, even safe supply means very different things in different contexts. And I think also when we're talking about drug checking or different elements, So I think it's very important to be very specific and to look at what we can do in different ways.
Fine. Would you agree with me or not that safe injection clinics tend to increase criminality in local neighborhoods rather than decrease them?
So on our website, you can also find, we did do an evidence brief last year around supervised consumption sites. The evidence thus far from across the country is that supervised consumption sites do not increase the crime in the neighborhoods around them, and that they don't increase violent crime either. That being said, you know, this is again where, as I was speaking to your colleague, we have to meet communities where they're at. So if communities don't feel safe, it doesn't mean that we need to be dismissive of that. We need to have conversations about how we help people feel safe.
Are you familiar with Chief Truong of the London Police?
Not personally, no.
But you've probably heard that he garnered quite a few significant headlines last year when he testified that a considerable amount of safe supply opioids in London are diverted for criminal purposes. Are you familiar with that testimony or with that practice?
Yes, I am familiar with that testimony.
In fact, Chief Truong testified that the diversion of safe supply drugs makes up the majority of all drugs seized by London police. Is that a yes?
So I can't speak to the specific data in London, but there has been data published around what is the proportion of opioids that are prescribed in every city that are related to safe supply or not. And it does vary significantly from city to city.
So basically, London police concluded that the majority of drugs that they seize are actually safe supply drugs rather than street drugs. Do you find that perplexing?
So I can't speak to the specific seizure data in London. I can speak to broader trends across the country around seizures, in which prescription pills are a piece of it, but still remain a small piece compared to precursors and other synthetic drugs.
And in your understanding, what is done with that diverted supply? Why is it being diverted?
So, unfortunately, diversion has been an issue for a very long time, and it is, diversion needs to be considered very seriously.
But what is it? Can you tell me?
I think people will purchase pills or things, and you're going to see this across. You'll see it with benzodiazepines, with opioids, and they'll purchase it because they can't get prescriptions themselves, so they'll probably take it.
People take safe supplies and sell them for illicit drugs on the street. That's what the practice of diversion means, according to policing. Sir, are you familiar with the name Carolina Hubner Makurat? Do you know who that is?
Yes, I do.
That is a woman who was gunned down outside of the South Riverdale Community Health Center in Leslieville in Toronto. Do you remember that episode?
Yes, I do. I lived 5 minutes walking from there at the time.
She was a mother of 2 children that no longer have a mother. Yes. Seconds. Do you believe that it would be safer for someone to live next to the South Riverdale Community Health Center or further away from the South Riverdale Community Health Center?
So the evidence thus far demonstrates that there is no risk of increased violent crime around a supervised consumption site. That being said, as our organization has said repeatedly, law enforcement needs to be provided with the resources to target violent crime, transnational organized crime that's becoming increasingly complex, and yes, increasingly violent in their pursuit of trafficking and other things.
Crime around a consumption site is the same as everywhere else.
Mr. Baba, the time is up.
That is what the evidence says thus far, yes, sir.
Well over, actually. Ms. Jasek, for 5 minutes, please.
Thank you, Chair. Dr. Corderella, the chair of the board, Dr. Francis Scuti, has given us an example of something that he feels is incredibly important. In other words, getting a roof over somebody's head who is homeless, who shows up in the emergency department, and who is someone who has abused substances. How do you take that kind of program and obviously, it's a gap in many communities across the country that are not providing this. That sounds like, obviously, a very important initiative. How do you promote this as an organization? What does CCSA do with recommendations that come from board members and the discussion, I'm sure, on a regular basis? How do you disseminate that information about gaps in service to provinces and territories and municipalities?
Well, I think it's an excellent question, and there's multiple pieces that are needed. One is often more data clarity is critical. So what is happening? This is why, for example, we're undertaking those studies to understand, well, what are the treatment needs and gaps in communities? I think the second piece is to help really understand what are the needs in a community more specifically, and what might be the implementation challenge. It's, for example, why when we talk about that Small Cities Initiative, we're talking about not just what are initiatives that worked in other cities, but what are some of the facilitating factors that might increase or decrease the likelihood. Sometimes you hear that it's, you know what? It's the fact that the police chief was willing to meet in a health system for the first round table. That broke the ice. And it's what are the implementation challenges that might help? So not only how do things go, but how do they spread? Sometimes it's about connecting people as well. So for example, in one of the pieces that we're deeply involved in is an initiative called Digital Front Door, where people have access to a triage that will help them. They ask for help, and then it either sends them to a doctor or a peer, depending on their needs or all these different elements. But we need to understand, and people need to be connected to know what's happening and to be able to actually implement those things. So this is where our networks are very, very powerful. Our reach is very powerful, but also our ability to evaluate the evidence and compare different programs can be very important.
And do you send this information to Health Canada? Do you in any way try and tell them how transfer payments to provinces and territories might be structured with specific recommendations to address specific needs of the population that you're serving?
Well, we're very fortunate that we have a very good relationship both with Health Canada as well as provinces and territories, and they do frequently come to us asking what the advice is, what the evidence is, and what things might work in their jurisdictions and how. It's one of the things that gives me a tremendous amount of hope. It's the same thing with Health Canada in terms of how they may come to us and ask, what is the evidence or what pieces might work in a particular community, or even yes, you're right, what are some best practices? And not only in the country, but just a few months ago, we signed an agreement with the European Union Drugs Agency because we want to bring even more of these best practices from around the world back home as well, so that people have menus of options to choose from that really are the best of the best. It's why we're involved in global standards right now around, not only what needs to happen in pediatric care, but what should happen for concurrent disorders. People have mental health and substance use issues at the same time. What is the gold standard care that we should be offering them? So we're involved in a lot of these pieces, and we often do it in collaboration with other organizations to increase the dissemination. We were talking about cardiologists. That's where, for example, they are the ones who are going to go and disseminate that to all the heart doctors about how exactly we can improve the care of patients like that.
Do I have more time?
You have 42 seconds.
Any other international best practices that you could quickly illustrate for us?
I think we're doing a lot in the prevention space around that too, to try and bring some of these things. I think a lot of the things that can be looked at reducing violence and how to deal with that and how to reduce elements. I know there was a question previously around stigma. I think, again, how do you not become overly permissive with substance use, but at the same time you want to make sure that no individual who uses drugs experiences stigma, that the individuals aren't stigmatized, but that as a population level we're working to try and reduce the amount of problematic use. This is something that other countries have wrestled with a lot and have tried different approaches, different communications approaches. We're, for example, working with some international organizations that want to speak to people who aren't English first language in Canada to support them in culturally relevant ways. So I think you're going to see a lot of really interesting things come from that.
Caruella. Okay, now I'm going to go to Monsieur Blanchette-Jonca for 2.5 minutes, please.
Thank you, Madam Chair. So, Dr. Catarella, what concrete results can you give in terms of the reduction of addictions? I would say that what we've observed, we talk about opioids a lot, but in terms of alcohol, we can't ignore the impact that the work has had, not only with people who are addicted. There we can see a reduction in numbers, but we know the majority of cancer cases arise in people who have no addictions, or who have addictions rather. So we can see reductions everywhere. We're trying to determine why and where there were decreases in deaths related to opioids and stimulants. So how do you measure the real impact of your actions on this? What are your performance indicators? We have several. We have a department that measures that precisely, because we're not always having direct interventions with patients. Are people still using? And is their life improving? One unfortunate thing in this country, and one of the reason is that rather we can't tell for the majority of people if their situation is getting better or worse, and we're trying to we're trying to find measures that each province and territory can use in order to determine that. So you're saying for the majority of people, you don't know if the situation is getting better or worse. You don't necessarily have data that's solid enough to say that current policies are working. Well, what we have, we can show that workforce competencies, that the level of help that's come through a site has improved the situation. A question inaudible. The answer, the crises are complicated. So we can see that costs and economic effects are reducing, are going down.
Merci.
5 minutes, please.
Thank you. I have a question for Mr. Areo. You told CBC News in 2016 that the number of overdoses you were seeing in Vancouver in 2016 was excessively high. The number of overdoses in Vancouver are even higher today, as you know, higher across the whole province, and the number of overdose deaths is significantly higher than 2016. If overdoses were excessively high then, how would you describe them today?
Thank you for the question. So in 2016, at that time, I was managing Insight, or co-managing Insight, one of the first sanctioned supervised injection sites in North America, and we started to see those numbers really become inflated. Since then, as you mentioned, those numbers have consistently grown, almost exponentially. It's really unprecedented. I don't even think that there's a word that I can encapsulate that would capture how much it's grown.
Is shocking. So the prevalence of drug, Mr. Rayo, the prevalence of drug consumption sites in BC has increased exponentially in the last decade, but so has the number of overdose deaths. So do you view any correlation between these two increases? More sites and more overdoses?
I think, like Dr. Cottarello was mentioning, I think the use of the supervised consumption sites is really one intervention in addressing some of those harms. And when it's done in in conjunction with the communities that they serve, there's an identification with the health authorities and the communities of what would be the best approach to dealing with a lot of the overdoses. So even with the supervised consumption sites, the main intention is to reduce the overall consequences of using solely or individually and all the overdoses that are related to that. So
Doesn't really seem to be working, would you say? I mean, the numbers don't work, and we've talked a lot today about data. Your organization works with data. This is very obvious data, and I would say that the two numbers are both rising, deaths and consumption sites. So do you think that those are correlated?
I don't, because I think from an evidence perspective, the supervised consumption sites are, again, just one intervention designed to reduce those immediate harms and really connect people to care. And in that function, the number of overdoses that are reversed within those sites are consistently high. So can you imagine if those were absent, the number of those deaths would even be more?
You imagine there'd be even more. So today we've talked a lot about, there's been a lot of talk about the continuum of care. It's been said that distributing drugs at consumption sites is part of a continuum of care. I wondered if you could answer my question about, I've heard a lot about a need for a continuum of care, but the only option, for example, in my community, there's no option for that continuum of care. If someone's at a consumption site and they decide, as you said, they decide, I'd like to quit drugs, I want help, please help me, there's nowhere for them to go. In fact, I was told by a resident that, involved in this system, that in my communities, in the community, that there's it would be a 2-year wait, for treatment, and it wouldn't be, by the way, anywhere in our communities. Anywhere, it would be somewhere else they would be sent. But after 2 years, I'm sure you understand what that means. Could be a death toll for somebody. So, what do you say about opening up these consumption sites and yet not having actually a continuum of care in place, especially in rural communities?
One of the examples that I often refer to is Insight. One of the really
30
novel
seconds.
things about Insight was that it had a treatment recovery program right above it. Right, so there were two doorways, one into Insight, and then the other one.
So what do we do? Should we continue to build safe injections or safe sites or whatever it's been called? Should we continue to build them if there's not the treatment available for people to actually quit drugs? For actually, if they would like that.
I agree with your sentiment that I think all of these different interventions have to be scaled accordingly. So if there are those harm reduction sites or supervised consumption sites, there also has to be accessibility to treatment. Having something operate in a vacuum or in isolation is not going to solve.
Maybe we should hold off on more consumption sites until we build the system, build the continuum of care. Let's build the continuum of care before we build any more consumption sites. I would say, I think that's what you're saying.
Very much. The time is well over on this one. I'll go to Ms. Sidhu for 5 minutes, please. Sonia.
Thank you, Madam Chair. My question is to Dr. Kadra. With Bill S5, the Connected Care for Canadians Act focused on improving secure data sharing across our health system, how important is timely and connected data in responding to the overdose crisis, and how can it help frontline providers to save lives?
Thank you for the question. I do just want to very quickly address one of the comments that was just made, and just to say that CCSA is here to work with your communities. If you are hearing things from your own backyard, from your own constituents, we encourage you to come to us and to see, can your hospital, university, clinics, providers be integrated into some of our initiatives to try and improve the care that's offered there. So that's an open offer that CCSA has for all parliamentarians, and I really encourage you to reach out to us and see how we can support the needs of the community. To answer your question, I think you heard from Dr. Fetchiskitty earlier that right now people are not being either provided the care on the spot often or connected to care. in this country, the care you receive is often based on where you are, who you are, how you present, and who you happen to meet. I think that because there was such a desire to solve the problems urgently and sometimes such a fear about working together because everyone wanted to be that hero, we sometimes didn't link things together or connect them as well. That's why an organization like ours can be really important in helping connect those dots. There's the things that are funded by the federal government, funded by the province, funded by the municipality, sometimes even funded by different departments in the provincial government. How do we connect all these things? And I think absolutely having more data sharing and having more ability for people to clearly not only see what's happening, but see if people are getting better or not, I think pulls them in. One of the parts that's missing the most is actually around community level data, and that's what we're trying to change. We feel that in order to activate people across different sectors, they need to understand. You know, one of our as an example, one of our workplace things that we were able to find out after interviewing over 1,300 people was that managers in many of the safety-sensitive employments had higher rates of use than the employees themselves. So how do we actually provide them with the data of what's happening, not in an accusatory way, but in a way that allows them to act on it? I can't tell you how many mayors of small cities tell us, tell me what's happening in my town or city so that I can address it in a meaningful way and provide resources that's actually needed. So yes, across the health sector, but I think data also needs to be shared across health and law enforcement and across different government departments at all levels of government much, much more fluidly.
To follow up that question, you highlighted when all level of government work together, we can see the real progress. You gave the example for the alcohol addiction. Can you speak to the value of the collaboration? You're just talking now about that. Is there any example you can share? We have seen any government working together to improve outcomes in substance use. Any example you can share?
It's an excellent question. I think we have. So many to choose from. Actually, you know, in the government of Newfoundland, we've seen tremendous collaboration between the federal, provincial, and local governments, actually around alcohol further, and trying to figure out how information gets into people's hands as quickly as possible so that the public health messaging lines up with the messaging you're getting at your local physician's office, lines up with the messaging you're getting in different places. And so it's often about hearing the same thing over and over again. I think another instance in which we've seen it work very well is, I previously mentioned Timmins, but I think that's a great place where you see municipal, provincial, federal collaboration. Often it is a strong local leader who's willing to bring things together. Another place where we've seen really wonderful things is in Victoria, where there are some really interesting partnerships between the provincial public health elements and the local police to try and figure out how they can work together. And there's all these amazing pieces. Like, this is again where, especially when it comes to things like public safety and public health, we don't need to fear working together. Yes, there's things that we need to consider and mitigate carefully, but it's not something that needs to be feared in any way.
Thank you. I think that time is up. I now wanted to just tell everyone that we are supposed to use the full 2 hours. We end at 5:45. So we have time for another round, if you wish, for everyone, because we have about 20 minutes, 25 minutes. I just wanted to correct something for the record. Overdose deaths in British Columbia and in Canada have been going down significantly. Opioid deaths have been going down by 22% since July 2024, and stimulant deaths have gone down by 38% since July 2024. Just for the record, that in fact deaths are going down in some of these places. Thank you. Before we begin with Mr. Strauss, for 5 minutes, please.
Since you brought that up, how many people is that a day then? If it's down by 22%, how many people are dying a day?
I don't have that information on hand, Mr. Major, but I know it's going down, and it's been reported in 2024, 2025, and the coroners in various provinces have said it's going down.
You don't
So,
have it. Can you find
and
that
it
number?
might be a question to ask why.
Yeah,
is
well,
it going down?
if you could find out that number and report it back to the committee,
Sure,
that'd
I
be
will.
appreciated.
I will.
Thank you.
And if I may,
Good.
I'd like to follow up and find out from the chair why she particularly decided to start tracking some such data from 2024 as opposed
point
to
of order.
2025, 2015, or 2019. Why start at 2024?
Starting at 2024, Mr. Barber, because that's when it started to decline. Before that, there was an increase. It's declining since 2024. That's the only reason I use 2024. Thank you.
So, Chair, I just wanted to ask, you believe that safe consumption sites are working then in British Columbia?
And we heard,
Or elsewhere.
I'm not a witness here, but I would like to answer that question. When we had the minister and her bureaucrats here, if you recall, I asked the question, how many overdose deaths had there been since safe consumption sites were opened? And I was told 0. Thank you. House for 5 minutes, please.
Thank you, Chair. Dr. Cottarella, it's clear you bring a lot of expertise and still enthusiasm to this testimony, so thank you for that. And it seems like you're very committed to reducing harms from substance use disorder and addictions. You had a conversation with my colleague, Mr. Blanchet-Chanca, about funding, about budget, and you said your budget's about $11.5 million. You could do more if you had more. If the federal government gave you $250 million, how many lives do you think your organization could save with that amount of money, or other sister organizations? I mean, I'm sure you only have the ability to scale up so much capacity. What would be a good ROI? Like how many dollars per life saved?
So I think our sector needs to do more around understanding exactly what those ROIs are. We know, though, that I think the sector needs more money, but I actually think we need to spend the money better. And I think we have a lot of money, not from all levels of government, that I don't think is being ideally spent.
Would you give me your elevator pitch right now? If we wanted to give you an extra $2 million, how many do you think you could save?
I think every day we turn away both communities and sets of providers. We don't turn them away. We work with them, but we're not able to do everything they want to do in action the next day. So I think what it would allow us to do is to do more work that would,
Would you come up with an estimate and table it with us?
Sure.
I'd love that. Thank you.
What I will say, though, that I think is important is we need to focus a lot more on why people make the decisions that they make.
And to that point, we had a conversation about stigma speaking with another committee member. You said you wanted to make sure that no individual person experiences stigma. So if I were to get drunk and drive back to Kitchener tonight, 5 hours on the highway, do you think I should experience stigma as an individual for that?
So I think no one should experience stigma for the fact that they are a person who uses drugs. I think they need to be given support and not. People are complex, and so are their behaviors. Just because people who use drugs aren't bad people because they use drugs doesn't mean people don't do bad things or things they shouldn't do. It's why we talk about autonomy and we talk about people's ability to make decisions.
People are social creatures, though, and part of the reason why perhaps I do not drive home drunk tonight is that my parents would be disappointed, my wife would be disappointed, my kids would have negative outcomes from that. Like I would feel that social shame, and that's part of what influences my decision making.
One of the things we know about prevention more than anything else is telling people not to use drugs doesn't work. What works is working with families to build good expectations and boundaries and different pieces. So building healthy societies is absolutely critical.
In conclusion, you and your organization are going to work to make sure that I don't feel stigmatized if I drive drunk tonight.
So we've actually been doing a lot for many decades in the drink driving space to try and reduce those rates and working directly with health and law enforcement. So at no point did I say that people shouldn't be stigmatized for doing things that are harmful. I think people shouldn't be stigmatized because they have health conditions. It's very different. In the same way that somebody who may have fetal alcohol spectrum disorder, where their cognitive development is impacted by what happened to them. Doesn't mean that if they commit a crime or hurt someone, that person deserved to be hurt, or that there shouldn't be punishments for people. But we need to understand why people do the things they do. We don't.
That stigma is part of what, like, every human society has taboos, has stigma, has customs around shame and forgiveness. And it seems to me to say, here in the West, we're deleting that. We are getting rid of taboo, we're getting rid of stigma as a federal government prerogative. That seems crazy.
What I've said repeatedly, and I believe in, is we do want to reduce the amount of substance that is used, because when at a whole society level we see less use. Does that happen through cultural change? Absolutely, right? Does that happen through cultural norms? Absolutely. So
I don't think you disagree with me, and I want to give my colleague, Mr. Babbers, the rest of my time.
You could give Mr. Bader some time, but he only has 12 seconds. So if he wishes to take 12 seconds, I'm going to cut off at the right time. So 12 seconds, please, Mr. Barber.
Sir, is it safe for a child to find a used drug needle near a playground or on a playground? Yes or no?
Obviously, the answer to that is no. In the same way that, we would.
Thank you very much. You've answered the question. We're moving on now because we're now 14 seconds over time. I warned you, Mr. Barber, about your time. I cannot let one person go well over time. We're now 14 seconds over time. Thank you. So, I gave you that. You have no idea how quickly time flies. I'm sorry. So now we're going to Ms. Chi for 5 minutes, please.
And since our conversation got cut off because of time, I want to come back to Mr. Elliott just to finish what you were saying before.
Great, thank you. So when we look at opportunities and solutions that are working in different parts of the country, a lot of them need to come from the frontline organizations themselves. We have a lot of government initiatives, big ideas, great ideas that we push down. The problem is that, as was mentioned earlier, the solutions for this population are acutely local, because everybody in our community, we operate in a different way. So we've, over the past 8 years, we've worked with about 400 to 500 organizations across the country, and trying to connect them as well with some of the services that they are bringing to the table. And there's lots of solutions that exist. One of the issues is what was already mentioned, the siloed funding and policy, about also the jurisdiction, and stigma is a thing, it is in the sense that if someone doesn't have the opportunity to talk about something, they're never going to have the opportunity to be able to overcome it.
Oh, thank you so much. And my next question is for Ms. Russell Sani. Did I pronounce your name right?
Chani, but thank you.
So from what I read, you work with youth. Is that correct?
I do not work in the front lines with youth. In the past, I have worked in the front lines. My work currently is as a consultant on a large research project called the National Standards of Child Welfare.
Oh, okay. And how do you find, in your work, in your research, how has it helped, in assisting CCSA in, making some of the recommendations? Dr. Cottarella did mention we're seeing a trend towards young people, and sort of wanted to share from your perspective what you're seeing and what do you think is useful next steps.
Thank you for the question. From my own experience, it's helped to score the intersectionality and the nature of substance use and the interconnected systems that shape it, as well as the advocating for a gold standard, as my colleagues have so eloquently stated today already, that CCSA is working towards the gold standard that's rooted in inclusive evidence, and that our work is community. It should be community defined. It should be responsive to community needs. My work on the front lines and in policy and in advocacy, in my own lived expertise, has underscored each of those. And when I approach my work with CCSA, it is to improve the lives of people in Canada who use substances, and to ensure safer communities for all. And I have just a deeper understanding of how that plays out in the day to day because of my lived expertise in the intersectionalities that exist.
Excellent. Thanks so much. And my last question, I think I still have time for one last question, is to
You have
Dr.
1 minute and 35 seconds
Yes,
left.
thank you
Maggie.
so much. Cautarella, time sometimes passes faster than you think. We've heard a lot from the table about, trying to, I want to say, oversimplifying the issue of addiction and mental health. I want to ask, what are the dangers of using a one-size-fits-all solution, oversimplifying the situation? If you can share some of that.
Well, I think when we oversimplify things, people disengage, because this is the problem where we're in such a competition to not only be right, but also to, I think, sometimes mislead about the potential harms of things. So people don't get what they bargained for, they disengage, the problem remains the same. I want to remind the committee members that 38 years ago, it was the Standing Health Committee that came up with, across all parties, 20 recommendations of things that were felt to be moved forward. I think the medical field feels very strongly that there are 95% of things in this field that we agree, if implemented properly, would change things. And one of the challenge I'd put to the parliamentarians, how do we get back to this space where something this important can be worked across not only party lines, but across different levels of government? People are dying, and I think that there's an importance that we find ways to be honest about what's going on, honest about the risks, but also continue to evolve and grow and change our approaches to what we're doing. We actually know the solutions. We know how we could turn around and save thousands of lives tomorrow. We just have to be strategic and collaborative about doing it, and less about cutting down maybe what's not working perfectly, and more about building up what has great potential to work.
35 seconds, Maggie.
Thank you so much. I think what you touch on is bang on. Is how do we respond with agility and flexibility? Because if one approach doesn't work, you gotta. It's a people's lives, right? You gotta go to the next one. You gotta try different things, right? And I know there are some things said about supervised consumption size not connecting to services. Is that your experience? Is that what you've been seeing?
I mean, I have clients who have stopped.
Thank you. I'm sorry, Maggie. I let you go about 50 seconds over time, almost a minute. Yeah, I was, my bad, I wasn't paying attention. So, everybody can crucify me for that. But, okay, so there we go. Now, Mr. Blanchette-Jonca, 2.5 minutes, please. Maxime.
Beaucoup, Madame la Présidente. Monsieur
Thank you,
Cautarella.
Madam Chair. Mr. Cautarella, you talked about acting strategically and to engage in collaboration. Can we really pretend to fight against the opioid crisis, one of the biggest public health crises in our history, while we slow down the growth of provincial federal transfers for health? I would say, well, I'm not a representative of the Canadian government, but there is resistant even to have health transfers dedicated to mental health or to the reduction of substance use. So we have to spend a lot less time discussing about who will get the most money, but spend more time on discussing how we measure the responsibility or we count ourselves. But do you agree that prevention is cheaper than treatment? Absolutely, prevention is crucial. And what gives me hope is that communities nowadays want to focus on community prevention measures. How can we do more prevention if we don't have the means to do it? The health transfers have gone down. The costs of the health care system in Quebec, for example, will be greater than the health transfer amounts. So how can we do that if we don't have the means to do it? So I'm a doctor, and there's no way I'll tell you that I want less money in the healthcare field, but I'll say it in English.
Not a capacity problem. Il y a 90% des personnes dans le domaine de santé qui ne travaillent pas pour aider
90% of people in the healthcare field are not working to help people who have problems with drugs or alcohol. It would be fine if we had 10 or 20,000 more doctors in the country, but I would like that the 30,000 primary healthcare doctors work in that field. So I would like to present a motion that, given the recommendation on 2 meetings for the position of Chief Administrator in Public Health of Canada and that for President of the CFIA, the committee invites Harpreet Singh, President of the CFIA, and Justice Reamer, the Chief Administrator of Public Health in Canada, to appear each for an hour to discuss their mandate in the 2 weeks following the adoption of this motion, and the committee use supplementary resources if necessary to respect that delay, and that the committee ask the Minister of Health to send to it in the 5 days following the adoption of the motion the complete list of the members of the working group on the sector of pharmaceutical products and life sciences.
Been given 48 hours notice. You're tabling it today. We won't debate it today. We'll have to do it at another meeting. We did not get 48 hours notice. Pardon?
So this is relative to what we're discussing today, since we brought in officials that have been appointed. So it's at hand. So it can be considered.
Don't agree with you that it is relative to what we're doing today.
Well,
It's broader than what we're doing today. But if the committee wants to say, let's go ahead with it, let's go ahead with it. I'm feeling very generous today. Okay, Maggie?
Sorry, I just don't have the wording. I put on my translation a little bit too late. can we pause to see the wording? I need to see what the wording is. Yeah, suspend. Please. Yeah.
order again. Now, I am asking the committee for unanimous consent to look at Mr. Joncar's motion because it's not been given 48 hours notice and it's a totally different issue. It's about food and it's about public health and it's not really about the issue of this committee that we were trying to talk to. So you want to give him unanimous consent to table it? Am I hearing a yes? Am I
Sure,
seeing a no?
unanimous consent.
Yes, okay, good, good.
If you seek, you also find unanimous consent, you see on adjourning the meeting as well. Thank you.
We haven't asked to adjourn the meeting. I'm asking first, is there unanimous consent for Mr. Joncar to table it? Now, are you suggesting that the meeting be adjourned?
Table, is it adopted?
Motion would be passed, right?
Pardon?
I want to clarify.
No, we will pass the motion today. We will pass the motion today. You see to.
We have a motion to adjourn, which, as you know, is not debatable. Did you say adjourn or adopt?
Adopt first. And then to adjourn.
You don't want to debate the motion, you want to adopt it.
It's unanimous consent.
Okay, so we don't even have debate. Well, that's great. My goodness, somebody's smiling on Mr. Blanchette Joncar today. Somebody up there is smiling on you. So we are passing your motion without debating it. That's great. Thank you. So the motion is adopted, Madam Clerk.
Yeah.
And then, did I hear somebody said they want to adjourn? Okay,
You see to
then
adjourn, yeah.
this meeting is adjourned. Thank you.